For joining. I'm Ariel Smits. I'm just for those of you who don't know me, I am the medical director for the Health Evidence Review Commission. This is a meeting of the Genetics Advisory Panel, which helps to advise HERC staff on all things genetic and genetic testing related. And because of that, we don't need a quorum. Everything that we discuss today will be brought to, as long as we come to an agreement and a conclusion, it'll be brought to the November 14th VBBS and HERC meetings for further discussion. I guess we should call the meeting to order. And let's see, I see Karen Kovac, Carl Stevens, Nicoletta Voyan, Catherine Murray, and Jilla Thalberg. And then Jeremy Mihailovich, I'm assuming you're a guest. So we run this meeting a little bit more casually than a lot of our meetings. So feel free to come off mute, raise your hand, message us like Karen just did, whatever you need to do to get our attention. I guess the first order of business would be the highlights from our October GAP meeting last year. Did anyone have any changes, corrections, other concerns about the minutes, things that you want corrected?
No.
Okay. So unless anyone has any concerns, we'll just consider those approved. Again, this group doesn't take votes, although your input is hugely, hugely valued. So, okay. So as you can see on the screen, we reviewed the highlights. The real staff report. One of the biggest things that you'll hear from Jason in a few more minutes about is that we are in the middle of doing a very large benefit update project review. So you hear a lot more about that. That's taking up a lot of our bandwidth right now. Any other staff report, Jason?
I think that's the headline.
Okay.
Yeah.
And then you all can see the items that we're going to be discussing. Apologize, apparently there was some issues with the materials, so hopefully you all got the revised link so you're all can follow along. We'll also show things on the screen. Any questions about topics for the meeting or anything? Otherwise, we can have Jason kind of launch into his discussion of our benefit update project.
Yeah. So as you may or may not have heard, our agency renewed its waiver couple of years ago, 2022. Part of that agreement with CMS is that the prioritized list, which is our primary work here at the HERC, is going to need to, it's being removed from a waiver, and therefore it doesn't make sense to maintain it. So I'm going to just describe that changes for your purposes for this group. It's going to be more about things being called different things than about substantive change. So I'll go pretty fast, but please feel free to stop me if you have questions or concerns about what I'm saying. So again, our waiver ended. The structure is transitioning, but the operational elements will continue. We'll keep doing our evidence review, expect to continue to have this panel. We'll still look at which codes are appropriate for which conditions and when they're medically necessary and when they're not. And our public processes will continue. Each state has a state plan. So this is kind of the background for the change with CMS. We'll dive into Medicaid law. You know, our state plan is very high level. It defends benefits, physician services, lab and x-ray services, and you know, genetics would fall into this lab services, which is a mandatory benefit that all states must cover. And there are two key federal rules for our purposes today. One says the state may not arbitrarily deny or reduce the amount, scope, or duration of a required service because of the diagnosis, type of illness, or condition. And that's what we what is waived. And it just allows Oregon to exclude things from the benefit package that wouldn't be able to do in other states. Since these services, genetic services, are diagnostic in nature, that doesn't really affect us. This is more about the actual conditions that are covered on the prioritized list. However, it does also say that the state, including our state, may place appropriate limits on a service based on criteria such as medical necessity or utilization control. And that's our purpose here. And that was never waived and will remain in effect. Again, this is our waiver. I won't go into detail about that, but that's what's going away. The bottom line here is that we will use the state plan, we'll use medical necessity policy and utilization management techniques. We will continue to find benefits at a high level in the state plan, and then we'll have our HERC policies and administrative rules to provide medical necessity policy. So the diagnostic guidelines that we work with here will continue to exist, but their names will change slightly. This is a lot of this is just saying there will be some additional covered services that are currently in the unfunded region of our prioritized list, and we expect some cost from that. But the legislative funding line will go away, the ranking will go away, denials based on the funding line will go away, and the comorbidity rule, if you're familiar with that, will go away. Again, we will still have coverage decisions, we still have denials based on medical necessity and benefit limits. We want our members to get services that are safe and effective and beneficial for them, and we'll continue to make these decisions in our public process as we do today. These are just an overview of the services addressed by the prioritized list, and you'll see there's the lab and x-ray services. This is about the prioritized list itself, and again, as I said, this unfunded region will be going through it with our staff, and Ariel has already begun with that, looking at what should be newly covered as medically necessary because it's one of those mandatory benefits. What is currently down here because it's not medically necessary and needs to continue to not be medically necessary. A lot of the things in the unfunded region just need office visits, medication, and emergency services. No change needed. Some below the line conditions already have guideline notes, and those will be reviewed to make sure they are right. And if so, the condition will become covered, and those guideline notes will apply to covered services instead of being a little more hypothetical as they are today. Others, again, will require analysis, and Ariel is meeting with different specialty societies. Prescription drugs, criteria related to unfunded conditions or categories excluded because of the funding line will need to be reviewed and replaced with medical necessity criteria. So that's an analysis happening at the Pharmacy and Therapeutic Committee level. For dental services, we expect limitations on crowns, root canals, and dentures to be unchanged. Again, expect a budget impact. The money will need to be come up with. The rates will be actuarially sound for the coordinated care organizations, and the rate making process will go on much as it does today. Again, HERC level processes will change. We'll probably rename our value-based benefits subcommittee something else. But other than that, we expect the work to continue in much the same way. And here's a timeline of the project. We're currently right in here, and you can see this is one of our first public meetings where we'll be discussing things. again, limited impact on this group, but just want you all to be aware of what's going on. And then January 1st, 2027 is when we need to have everything effective and up and running. So with that, any questions on that project or about the regulatory changes that are coming?
And just to piggyback a little bit on Jason, for this group, pretty much all the tests that you talk about are either diagnostic, so covered, or they are considered experimental or whatever, and we don't cover them. I don't think that will change. I think that that dichotomy we can continue to have. And then the guideline notes will continue. They may become a, they may not be called a guideline note. They may have a different name. But essentially, I don't think this group's work will change substantially at all.
Jason, this looks like a pretty sizable project.
Yes.
Am I getting it right to say, as much as possible, the coverage content will remain the same, but the user interface has to morph to get at it mostly? Is that the deal?
Well, it's almost like what we call things will need to change. Like there'll be no reason to prioritize one line over another anymore. It'll either be, medically necessary or not, and then either be a guideline note or not. And some conditions that are now in the unfunded region, you know, fissures, fibromyalgia, nasal allergies, mild acne, well, instead of saying those are unfunded, we'll have to define what treatments are and are not medically necessary for those. And so I guess the intersection with this group, if there were a genetic test related to allergic rhinitis or fibromyalgia, that might change how we look at it. I think that's unlikely to be a high priority topic for genetic research, but who knows?
Okay. Is this deck that you're showing us somewhere in the public domain or not?
Yes, if you look at our October 10th meeting materials for either HERC or VBBS,
Okay.
it is included there. I'll pop a link to those in the chat.
Yeah, and Carl, for this group, I don't think a lot changes, but in terms of general changes, I'm going through by specialty, and some things we're going to be starting to cover sooner, like anal fissures. Some things we're just going to clarify. We've always covered office visits and non-PA meds for diaper rash and whatever, so that will just sort of look different, but I don't think that's going to substantially change. But there will be some additional benefit.
Okay. All right. Sounds like a big job.
Yep, it's keeping us busy.
Yeah.
I should mention too, we partly because of that, we are hiring a new half-time or thereabouts medical director to help Ariel with this bolus of work. So if you know anybody knows anybody who would be good for that, looking for an MD or a DO, that would be wonderful. Put them in touch.
I'll call my people.
All right.
Yes, please.
Carl.
Yeah.
I'm not on social media, so I'm limited, but
But yes, it's a big project. And some of what Jason showed you, I mean, pretty much it's baked, but there's still work going on at the agency and at the leadership level. So, we're not quite exactly sure what the final product will be yet, but this is at least our timeline and our process.
great. Thanks for bringing us up to date on that.
Does anybody else have any questions or ready to move on? All right, let's talk some genetics.
So the first thing on our agenda is just our yearly updating of all of the NCCN guidelines. Interestingly enough, high-risk colorectal has been expanded to endometrial and gastric. Interesting. Otherwise, these are just the usual version changes. The other thing to note is our prophylactic surgical treatment for prevention of cancer in high-risk women. there was a question about what a high risk woman, so it's at increased risk, just making a little bit more PC maybe. Anyone have any concerns about any of these? They're pretty straightforward updates.
So for the colorectal, there is now the 2024 in October 4th.
Okay, thank you.
No problem.
I will make a note of that and we will look for that before it goes to HERC. So there's a version 2, October 2024. Perfect, thank you. And I should probably look for the breast ovarian and pancreatic one more time before we bring this. That one seems to change quite a bit too. So, but thank you for letting me know that. I will update this to version 2 and put the correct date, etc. in there. Any other changes? Anything else anyone noticed?
Ariel, just sort of a practical question. You know, for those of us in Portland Metro, it's pretty easy to access genetic counseling elsewhere in the state. I think it's extremely sketchy and difficult. So is there any consideration for kind of softening the language? I guess you could go one of two ways. You could either lower the barrier in terms of counseling, or you could kind of facilitate a connection to the folks in Metro Portland, where I think almost all of the genetics counseling is available. Which is
We've been told that there's a pretty robust virtual visit component. So you don't have to come to the Portland metro area.
right.
But it is still a scarce resource. Yeah.
Yeah.
So what now we say genetic counseling should precede genetic testing whenever possible.
Yeah.
And I think that's already pretty soft. We made it whenever possible because some people get BRCA testing as they're waiting for their mastectomy. Some providers feel very comfortable ordering a panel. Actually, just interestingly enough, Jason and I were attending the med meeting yesterday, and one of the examples was a hereditary genetic cancer testing not ordered by a genetic professional and how it kind of went really sideways. So I personally think the wording is soft enough.
Okay.
This is Catherine, and I would agree with you, Ariel. I think it's soft enough.
Okay.
Do we know why the telegenetics companies like Genome or other are not contracts if they don't see Medicaid patients, or
I hadn't heard that.
something from their end or from your end?
No, they would have to be enrolled as an Oregon Medicaid provider.
Okay, so that's probably what.
Yeah, I mean, we can't pay them if they're not enrolled because you know, we don't we wouldn't know who they were and all that. And they have to agree to our rates.
Well, and then there's another link in that chain, which is the provider has to have a DMAP ID, and then
That's what I meant by being enrolled as a provider, getting a DMAP ID.
Yeah, and then the CCO has to have a contract with the lab entity of some sort.
Well, the lab, but also the genetic counselor, right?
Some of these labs have genetic counselors, I think is what
These
was
are not the labs. These are just the counseling, companies, because usually you cannot provide genetic counseling if you are part of a lab. So it's, unethical, and it's like, but all the Medicaid and Medicare, even the, health share Medicaid, they apparently they are not contracted with them. So we,
Yeah, that's
I
not an
guess just like
OHA
that.
thing. That's probably they have declined to take our rates or something.
Okay. And they function mostly on genetic counselors. So I don't know if it's a licensor issue or.
And Oregon passed a law a couple years ago. We now have like licensing of genetic counselors so that they can enroll individually as DMAP
But
providers.
are they credentialed by insurance? I don't know, because
I don't.
we don't, like in Providence here, we don't have.
Yeah, I don't know
Yeah.
the granularity there.
Thank you.
In my experience, the genetic counselors are functioning under the license of the board certified geneticist for the most part.
Right, but we do have this other pathway now where they can be their own. They can bill on their own.
Right.
And I have no insight into how all of the pieces of that work.
Okay.
So this
But
is
if you-
Karen. So with the state licensure for genetic counselors within the licensing, within the law, there's a requirement for a supervisory relationship with
So there has to be like a medical geneticist or somebody that they can
right,
consult.
for certain, yeah, but that doesn't, but one can still bill under our own name with the appropriate genetic counseling code, and the credentialing is done by institutions generally. So as an OHSU genetic counselor, we're all credentialed by OHSU. I didn't quite hear, Nicoletta, your original question.
Is that the companies like Genome Medical or, you know, other national companies will not, they're not contracted with Medicaid and Medicare. So my question was if it's an issue
mhm.
from the end of the insurance or if it's an issue from
I
the
think
end
it's
of
the
the
end.
company.
Yeah, I
or-
agree with what Ariel said. I think it's the company's decision whether to
Yeah.
figure out that credentialing piece. Yeah.
Because that will help, you know, will help a lot with the
Yeah.
backlog and other, but it is what it is.
All right. Anything else there? Are we ready to go on and talk about the CPT codes?
Sure.
Okay. Jason, can you share screen, or Jessica? It's the 2025 CPT code genetics.
Yeah, I'll share them.
Okay. So the first genetic code is for cytogenomic optical genome mapping for hematologic malignancy. And Carl Stevens had sent me an email a little bit earlier and noted that there's 3 PLA codes for rare disease identification using optical genome mapping that aren't shown. But basically, optical genome mapping looks at structural variants across the whole genome, uses ultra high molecular weight DNA. You guys probably know more about this than I do. The DNA images are converted to digital molecules, bioinformatically assembled to create a genome analysis. Looking at the evidence behind this, there was a consortium of international experts convened that was published in 2024. They talk about perspective and studies in clinical trials using optical genome mapping for hematologic malignancies are needed. That they're really, they think it's an important tool. It's probably going to be a very important piece of things, but that there's really not a lot of studies or trials. And then in 2023, there was a study, it was just a feasibility study. So this is a really new technology. And the feasibility study concluded that conventional cytogenetics are the gold standard, but that this is an innovative system, but it needs to have the techniques kind of standardized, and but it shows promise. And that's basically what another study for prenatal genetic analysis said too. It's a kind of an up and coming interesting tool. The private payers that I was able to identify coverage criteria all consider this investigational. So my summary, optical genome mapping, it looks like it's promising new technology. It's possibly applied to oncology care and testing for hereditary disorders, as well as prenatal genetic testing. But the literature to date seems to basically all be pretty much research setting. It hasn't really been standardized for clinical use yet. No specialty society recommendations were found that recommended paying or recommended using this, and no private payer that I could identify a policy for is currently covering this. So the staff recommendation is to place the new code, and then there's a friendly amendment for 3 PLA codes that would be added to this for the rare disease optical genome analysis. Putting that on our line 654 and guideline note 173 that will eventually go away. The line will go away. We're going to continue to have this specific guideline note 173 will remain. So all the things that we're excluding will remain. So what I would change on the here, Jason, let me just send you, I'll pop this in chat if anyone.
Yeah, we're gonna change the name of the guideline, but
Yeah.
it'll have the exact same function, right?
So there's 3 PLA codes that I just popped into the chat, and we would actually just take out the words hematologic malignancy, so it's a little bit more generic because those PLA codes don't actually relate to hematologic malignancies. Any discussion, input, thoughts?
As I said in my email to you, Ariel, I'm totally comfortable placing this where you have it. A good new name for guideline note 173 might be not ready for prime time, which is my sense of this test, because things are moving quickly. I found a bunch of PLA codes just using ChatGPT, and I think they're going to continue to, every little company that buys the machine that allows this test to be done is going to come out with their own test. So I'm happy having them all excluded from coverage. My one concern was, I think where this is showing most promise is in following the development of clonality and the hematologic malignancies, and the advantage there is the much faster turnaround time for results. The downside is you have to have somebody who knows how to interpret them and decide whether they're actionable or not. So I think that's probably a very limited number of people. And I don't know if it's possible to informally get the word out. You know, there are circumstances under which this could possibly be useful for certain conditions, that type of thing. In the somewhere in the guidance for the hapless medical director who's looking at a request from a specialist and trying to decide, should I make an exception or not?
You know, this is probably something that, since this is a really rapidly developing technology, I'm assuming we'll see more codes coming out. So this is something we'll probably be readdressing anyway.
Yeah.
I would assume that as well. And I don't think we have our lab folks on the call today, either Dr. Richards, who typically would attend.
Yeah, I don't.
Because I have heard a couple of lectures about this technology from the Night Diagnostic Lab. And it's certainly not my area of expertise, but I think asking Sue maybe in a follow-up email to weigh in on this just for any additional clarity, but I think this is the right call.
Did Night buy the equipment to run this?
I don't know. There's been some changes in the directorship of the lab, but I heard a lecture from the previous director last year kind of talking about this technology as being very promising. I just haven't heard a follow-up.
Yeah, it's definitely the new thing. What's interesting is Illumina is not making this machine. They make all the sequencing stuff. this is obviously a competitor to them, but Illumina
Yeah,
Labs is a separate.
different
entity.
technology. Yeah.
Illumina Labs is offering this using somebody else's platform.
I
Uh,
would echo what Karen said. So in between the directorship changing, because we send a lot of our prenatal samples to OHSU, they've also said that they're working on validating this. So I think getting input from the directors over there about additional evidence for it could be helpful for this conversation. And it's been a topic at like ACMG for a couple of years in a row now. With the ability to get structural like translocations and microdeletion duplications is kind of the benefit of it. Well, in my prenatal world is I have
Right.
one test. I'm not ordering 2 tests now to get all the information. I could condense it down to 1 is my very broad understanding of this. But I think having one of the
Yeah.
experts comment on it could be really helpful.
Okay, I can reach
They
out to
already
Dr.
have the tools in
Richards.
place because they were already talking about starting validation when I was having conversations with them like 6 months ago. So they might already have the equipment.
Does anyone know who at the lab would be the best person to contact for clarification?
I think
I would
either
start
of the
out with Sue
directors-
Richards, who's on this committee. Yeah.
Yeah, and I can send, I'll email Dr. Richards after this meeting.
Great. And if that's, please get back in touch with me to get you connected with some of the new hires if there's no response.
Okay.
Thank you. It does look like it could be really helpful for exactly what Jayla just stated, but I haven't heard more about it.
Yeah, it always makes me a little concerned when private payers aren't paying for something. We don't want to get out ahead of them, but we also want to stay
Right.
nimble.
Right. I'm there with you.
Okay. All right, so I have a game plan. I think I'll reach out to Dr. Richards and see if there's any other input. And if we put this on our non-covered guideline, I'm sure we'll hear about that when they do get it really up and running and standardized. So.
Yeah.
Okay. Anything else on the optical genome mapping? The next is a super straightforward. There's a medical genetics counseling service. We like medical genetics counseling services as we were just discussing a little while ago. So this, I think, should be diagnostic. That would go with we have a very similar code for patient family face-to-face. This is total time. So if the genetics counselor is spending a lot of time, getting background information, pulling a, guideline, whatever, that gives them additional time. Any concerns about that?
No questions.
Okay.
I think it's exactly what you said. It mirrors that, allowing additional time beyond what's just face-to-face, the same as the E&M codes changed.
Yeah, and yeah, right. So a family medicine doctor can actually now bill for more time than just face-to-face if they're like,
Right.
consulting records and whatever. Yeah. Okay, great.
And we all know how much time that non-face-to-face time is.
Yes. And then the last one, these actually aren't CPT codes, these are PLA codes. We normally actually don't review PLA codes, although we just did for the optical genome mapping. These, however, are additional pharmacogenetic tests for psychiatric medications, which we already don't cover. So just adding them to our list of currently not covered codes on our guideline note 173. So if you want to page down like a half a page, Jason. Yeah. Anyone have any concerns about that?
No, that seems right.
No, agree.
Great. Hold on. There's a little bit of noise in the background. Let me just close my door. I'll be off camera for 1 second. Okay. So our next topic is looking at testing of products of conception for recurrent pregnancy loss. This came to us from one of the OHSU obstetric and gynecology faculty. she's requesting that fish testing be allowed, followed by reflex microarray on the products of conception for looking for genetic causes of a miscarriage or a molar pregnancy. This was last looked at 10 years ago, and not much discussion at all about products of conception at that time. So most of these tests are diagnostic. Actually, they're all diagnostic. And our current prenatal genetic guideline is reasonably, well, I guess it does have a requirement for fish testing, and it only talks about it for karyotyping if you're needing a rapid turnaround for reproductive decision making. So looking at the evidence, there was sort of a review of in 2023 about diagnostics and treatment of recurrent pregnancy loss. And they talked about fish being limited because of the types of probes that are used and so it has some issues in detecting chromosomal causes of miscarriage, but then the array cytogenetics actually is the preferred method because it checks for lots of different things. And then next generation sequencing is still being researched and isn't standard of care. So for expert guidelines, the Royal College of Physician guidelines has one. They define recurrent miscarriage as 3 or more first trimester miscarriages, which is most of the US sources use 2 or more. And they recommend cytogenetic analysis be offered after the 3rd or subsequent pregnancy, first trimester or any second trimester miscarriage. And then ACOG in their 2016 guideline, they note that chromosomal microarray analysis identifies approximately 1.7% of patients with a normal ultrasound. So I guess that's not really products of conception. And then they talk about limited or inconsistent evidence as abnormal fish results shouldn't be considered diagnostic. So they don't really talk about products of conception. The American Society of Reproductive Medicine just talks about, again, like I was saying, the 2 or more consecutive clinical pregnancy losses. And then they note that karyotypic analysis may be useful in the setting of recurrent pregnancy loss. Most private payers do cover the genetic testing, which they usually defined as 2 or more consecutive spontaneous abortions. And then, yeah. So essentially, US and European guidelines note that analysis of the product's conception may be useful. However, they do note that these tests don't really provide information on prognosis or treatment. Most early miscarriages are due to genetic issues, and a lot of them are not anything that would affect future pregnancies. So it doesn't really change your management at all. It just provides an answer for why that particular pregnancy was lost to the patient and the provider.
This is Catherine. I just want to add something to that. It doesn't change it for that moment, but it certainly changes it for families who find out that one of the parents has a balanced translocation.
Right, but that wouldn't normally be testing on the product's conception, because the testing would be done on the parents.
We use the products of conception to see if there's anything beyond a straight trisomy, and then we test the parents to see if one of them have it. So
okay.
Because we can get an idea of how small the defect is, because karyotype may have a harder time seeing it if it's smaller. So the microarray on the products of conception can pick up very small copy number variants or very large ones, and then it can direct us where to look at the parents.
Okay. So, and I know, Carl, you had said something supporting coverage.
Yeah, so there are 3 levels sort of cytogenetics, starting with, just the traditional karyotype banding provides some information, obviously aneuploidy. Then in the middle sits fish, but also available is microarray. And that's a little spendier. I think we now I think 81229 is now diagnostic. That's microarray with single nucleotide polymorphism. So I think what's really needed here is, I sent you in my email what the fee schedule was for FISH. It's negligible, it's rounding error, and it's much cheaper to authorize those tests if somebody wants them than it is to deny them. But I think pushing people in the direction of a microarray, if you want to test the POCs, that makes more sense. You get a lot more bang for the buck with the microarray, even though it's a little bit more costly to do it, just because you get to survey the whole genome.
So for OHSUs, because this request is coming from them, and we also use their kind of testing strategy, their FISH reflux is really to help identify when to pivot to a karyotype versus when to pivot to the microarray. So it would be incredibly unusual just to stop at the FISH, because if
Okay.
we get FISH for a common trisomy like 21 or 18 or 13, they're going to give us a karyotype, and that will tell us if we need to test parents or not. But if we get a normal FISH result, then we're going to go on and do the microarray and looking for these other variations that a karyotype wouldn't be able to pick up. So it's
Yeah.
really, it is on their end kind of a cost saving measure on if we can get a karyotype on the fetus, then we know if we need to test parents or not. And we've kind of answered 3 people at once with that. Or we need to pivot to do more in-depth testing. So I think
Okay.
it's a really reasonable strategy for them to
Okay.
use.
So it sounds like we should add something maybe to the prenatal genetic testing guidelines, since we kind of have some restrictions for FISH and microarray. We could just put something in like genetic testing of products of conception is covered for the second spontaneous abortion or subsequent abortions with FISH, microarray, or other testing. Or something.
Yeah, with karyotype, FISH, and microarray.
Yeah, I think that's reasonable.
With karyotyping, FISH, and microarray.
Karyotype, comma, FISH, and microarray. There's different FISH codes depending on the probes, and obviously there are different arrays on the microarray, but
And we actually could probably leave the codes off.
right.
Let me ask this, is there any testing in this space? I guess after the first spontaneous abortion would be one case. We wouldn't want to cover it. Is there anything else potential for overutilization here, or is this?
I mean,
don't,
you get this gray area where like you have 10 pregnancies and you have 2 spontaneous abortions. That's normal.
right.
But I guess then you would rely on the provider to order it appropriately.
Say, yeah. And the number of people with 10 pregnancies.
Right.
Oh,
Yeah.
that
It's
used
just
to be-
I think
yeah.
we quote people like 1 in 3 pregnancies miscarries. So if you have
Mhm.
5 or 6 pregnancies, 2 miscarriages is reasonable, but I don't think we need to define it more. So, do you all, I can wordsmith this a little bit and send it around to the group just for final approval or final just comments. Does that sound reasonable?
Yeah.
Yeah.
I
Yeah, I
like
think
the
that'd be great.
That'd be great.
wording that you have there.
I would also, I don't know if it's worth noting this, but depending on how long the demise is, one of the big benefits of microarray is you're more likely to get results. So I don't know if that needs to be pointed out there specifically, but sometimes we go right to that depending on how long the loss has been and the viability of the DNA. So that's why it's kind of the gold standard in other places just to start there. But if we can pivot and get cultured chromosomes, it saves us testing the parents potentially.
And this kind of leaves it up to the provider that we were talking about.
Yeah.
Yeah, I think if we
Right, to make
state,
that call.
I think the
Mhm.
main thing is we just need to state that it's covered.
Okay.
Yeah.
Is
Okay, so
there verbiage I didn't wasn't reading fast enough about structural anomalies, or because we talked about recurrent, maybe this is just recurrent miscarriage, but
yeah,
it
we
was like or
cover
second trimester,
we
but I didn't
cover
know.
array for fetal congenital anomalies.
But on POC, like if they miscarry, would it be covered? Is that part of this policy?
That would be part of this policy.
Okay,
Did, yeah, so right now we cover array CGH for for fetal anomalies apparent on imaging, and fish only if you can't get things turned around with reproductive sort of deadlines.
mhm.
Okay, I will work on this. I will send it around to you all for final approval, but it sounds like adding just a statement to our prenatal testing guideline would be appropriate. Okay, thank you for that input. That was really helpful. And lastly, we have carrier screening. This is hopefully just pretty straightforward. We were asked to clarify because we have sort of carrier screening needs to be done at least the minimum testing, but that ACOG puts out, but we don't have a citation what we mean by that. So we as being the HERC has to reference a specific document. So we needed to put that in. And then the expanded carrier screening. I think the intent was that the panel would have the minimum, the ACOG minimum plus additional, according to the ACMG guideline. And then there was some concern about unbundling. So a note that when expanded carrier screening is billed, individual genetic tests are not covered. So these were just different questions that have come to us. And then there are two duplicative things about carrier screening, one in the prenatal genetic testing guideline if the person is already pregnant. The other is in the non-prenatal genetic testing guideline for a person who's contemplating pregnancy but not yet pregnant, and as well as their reproductive partner. Staff recommends breaking those out into one guideline because it's getting a little difficult to make sure that we mirror the two exactly. So basically the changes would be to say that expanded carrier screening needs to include at least the minimum test set that's recommended by ACOG. And that just a little note about not unbundling. There's a error actually that I've found in the prenatal genetic testing guideline about the fish codes. I guess that would have been appropriate for the last discussion as well. So just correcting those and then splitting out the guideline into its own carrier screening guideline. So for the prenatal genetic testing guideline, the only changes would be there's a grammar change in G, it referred to G, which should refer to F, and then clarifying the fish tests, and then deleting what we currently have in there about carrier screening. And then the non-prenatal genetic testing guideline would just delete the carrier screening section. And then we would have a new guideline. And already noted a friendly amendment. We need to put the reference to some of the ACOG guidelines. Anyway, so it would be a new guideline, carrier screening, and it would say this is covered for either a pregnant person or a person contemplating pregnancy, as well as the male reproductive partner. And it's basically the same words that we have right now in the two guidelines. So screening of the genetic carrier status with the minimum testing recommended by ACOG, and then we would actually refer to that ACOG committee opinion. And then expanded carrier screening would be, you need to have a genetics consultation, must be at least offered before testing and after the results are reported. And it's only covered when there is the more than 1 in 200 or greater per the ACMG guideline, kind of the same words we all have. And then that the panel also includes the minimum testing required by ACOG, and then not unbundling. Any questions about that? And then I just realized we were going to need to put in the 2021 ACOG or ACGME would also have to be a footnote. So putting that in as footnote 2.
This is Catherine. I just wanted to clarify. So if the expanded carrier screening included more genes than the 1 in 200, does that mean the whole panel is denied then? Even if it's the same price? Just curious.
No, I think it's at least 200, isn't it?
No, it says frequency of greater than 1 in 200.
Oh, I see. Okay, so you're saying for less common conditions, the whole panel would be excluded for more common conditions.
That's my question. That's what I think. I think the answer is yes, but that's what
Yes, that's the way I'm reading it.
I don't think we would want to do that, would we?
I don't think so.
I
Especially
see.
at the same price.
So we don't want to do what?
Limit if it's greater than, oh, limit for less common diseases as long as more common mutations are included in the panel, and the panel's the same price regardless because they're doing an exome anyway, probably.
So would you just get rid of B1? So it has to have a well-defined phenotype, etc.
It's sort of the severity of the known severity of the mutation or the polymorphism that can be detected.
I mean, that seems to be what would be in like 3, 4, and 5. It has to have a detriment, effect on quality of life, physical impairment. Have to have something that we can do early on, or education, that kind of thing.
Right, but in B it says in B it says expanded carrier testing is only covered when all of the following are met.
Right, I'm thinking we should strike out 1, the whole
Okay.
1.
Yes. Yeah,
Okay.
just take that out. Yeah.
Yeah, I think that's the easiest way to change that. Yeah.
Okay.
Good.
Ashley
Yeah.
Svensson, you have your hand raised.
Hi there. I have registered to give public comment and it's on this topic. Would this be an okay time?
Oh, sure. Yeah,
Okay.
we're kind of casual in this group. We don't
Okay.
actually like make you wait for a certain public comment.
Okay. Well, just for the sake of disclosures, Ashley Svensson with Myriad Genetics. We are a member of the Access to Equitable Carrier Screening Coalition, and I'm also the chair of the NSGC Practice Guidelines Committee, although I'm not representing NSGC today. So I signed up to make public comment. 2 things I wanted to make you aware of, and this was exactly one of them. So, we commend the state for covering expanded carrier screening. Most of the CCOs do reimburse, but there is one that is not covering expanded carrier screening because of that exact criterion that you've just struck.
Mhm.
So I think there was an unintended consequence of that, and this is what I was going to suggest. So I think now that we have the panel includes a minimum number according to ACOG, you no longer need that first criterion. So
Okay.
just going to make you aware of that.
Okay, so if we say it includes the minimum testing required by ACOG, that, and then all the other things about it being bad and all sorts of other.
Yes, then that aligns with the guidelines and all the health technology assessment that have been done on the current evidence. The other thing I wanted to add is that ACOG Committee Opinion 690 came out in 2017 and it was reaffirmed in 2023. So I think that date is wrong. I don't think it was 2020, it was 2017.
This date here?
Mm-hmm.
Okay.
Yep.
Can you
And
send, ACOG, they're always behind a firewall. Do you have if you could just send that to the
Yeah.
herc.info inbox, that would be great.
I definitely can do that.
Thank you.
I also wanted to share with the group that the ECS coalition is under the understanding that SMFM and ACOG have a new joint guideline on carrier screening in development. Potentially may even be published by the end of the year. So I don't have any details of that, but I just wanted to make the group aware that we may have new ACOG guidance on carrier screening soon.
You don't know an exact ETA, just later in the year?
Just later in the year. As you can imagine, the lab industry is waiting with bated breath, and we keep being told a few more months. So
if you do, I'm sure you're probably keeping a really sharp eye out for it. If you do see it published, do you mind just forwarding it? It's the herc.info mailbox will always get it to us.
absolutely.
Thank you.
And then just while I have the mic, and then I'll turn myself off, the NCCN colorectal guideline has, and I can also email this, has been updated just this month to version 2, 2024. And that was.
I'm sure it has. Thank you. Yes.
Yeah. So thank you so much for letting me participate.
Okay.
This is Catherine, if I could make a comment. I had a casual conversation that I was talking to somebody who's on the HERT committee, and I don't remember which physician it was, but that person didn't seem to have an understanding that carrier screening does not report out variants of uncertain significance. And so we don't get any ambiguous results, if you will. They're likely pathogenic or pathogenic reported out. And so part of this person's concern was if we include rarer genes, we're going to get more VUSs. And just for carrier screening, I'd like them to understand that they're not reported out.
So maybe Ariel, you can just include that in the issue summary, or?
I'm taking notes. Yeah.
Yeah, Catherine, is that a rule or a law or just a policy or a
It's
convention?
a policy. So in cancer genetics, we report out, in diseases, we report VUSs out, so clinicians are aware, because the interpretation may change. But carrier screening, we want the information right now to use, usually for this current pregnancy. So they actually don't report out VUSs unless specifically asked for. So we don't run into as many problems when we don't have time to work out whether a VUS is disease causing or not. We're just here and now for the immediacy of reproductive time. And so companies have chosen, and I don't know of one without asking them, they don't report out VUSs.
So it's just a convention, a norm. There's nothing to stop somebody
Correct.
from doing that.
Correct. So sometimes I'll have a parent who's a carrier who is maybe affected with a disease, and I'll actually ask them for VUSs for that specific disease and then kind of evaluate it on our own, whether or not it's clinically significant for that high-risk couple.
And so if we remove number 1 there, it's just requiring to include, it says the included genes. It doesn't say all the included genes. Do we need to add further clarity about that?
Well, I think it's very standard convention not to include VUSs, but it was part of the problem with this provider on the bigger committee that they thought that VUSs with rare diseases would create a whole bunch of problems. And I explained to her that they don't report out VUSs.
Right. I'm just saying the way it's written now, if I were trying to interpret it strictly, I could say, well, there's 14. Yeah, I guess you're saying that's not a problem, but it's the knowledge gap. Yeah.
Yeah, it's the knowledge gap. So that was part of the reason at least this person told me, some of the members' reason for limiting the number of genes was because of VUSs.
So you think this will address your concern here?
Yes, with the knowledge that the companies don't report out VUSs, so they can take away that concern of rare genes having results we don't know how to interpret.
Yeah, so I'll put that in the gap discussion part of what goes to HERC and just report out that that's the standard convention.
Do you think, and I'm kind of split on this, do you think it's worth commenting on family history for certain conditions? I mean, it's usually going to fall under buckets 2 through 5 anyways. Kind of in that B section on why I might order a certain panel or do something a little different. But I didn't know if it would be worth talking about like known genetic diagnoses as kind of a prompt to be going down this road as well in a family.
I think it's reasonable because sometimes we identify through cancer testing, mutations in like LZTR1 or other genes, and then we advise family to use that for reproductive risk discussion. So I think it's worth, because there will be rare, conditions that the carrier rate will be less than 1 in 200, but it would be important for that specific family.
Right.
Do you think we need
I
to
would
if we
agree.
strike that 1 in 200? So would that give you enough latitude? Because I'm not sure how we would write that, like, or some gene that, you know, is concerning based on family or family history, something like that.
I'm in agreement with the concept. I think it's just very difficult to operationalize that for a medical director at a CCO with general knowledge. Getting too far into the details on that just is a big challenge for folks trying to interpret that.
But if
This
we
is
put-
Catherine. I think striking the 1 in 200 would cover that. Also, when I have a rare disease and I'm trying to see if the partner is a carrier, a lot of times I can't even use a carrier test. I have to go to a lab to actually sequence that gene. And so that's when I write the letter of medical necessity.
So, and you're never going to be able to write a guideline to cover all those scenarios, right? It's just going to need to be an individual review for that. Is that correct?
This is Catherine. I agree.
Okay. So it looks like we're all in agreement to strike 1, and that would pretty much address 99% of our concerns. And then Ashley Svensson's going to send me the most recent ACOG opinion, the correct reference to that. Anything else? Okay, great. Any other business? You guys have been so efficient. We are way ahead of time.
Any other hot topics we should be aware of in genetics world?
Is there any trouble brewing in tissue of origin biomarkers area? I know there are a few.
Biomarkers. Yes.
I know
yes.
a few new PLA codes have popped up there.
Yeah, we don't, I mean, we don't have the bandwidth to review all the PLA codes. There's like 100 published every year.
Yeah.
If there are any that are becoming problematic, I mean, we can look at those, but in general, we just don't review them.
Yeah, we've been running a query to see if they're popping up in our encounter data, and when they do, we'll pay more attention. That said, I know many labs are not billing those, even though they should be. They're billing the 81479. So not sure what we can do about that.
This is Catherine.
Well, what I hear through the grapevine is that each one, so Foundation One is extremely popular with their tissue of origin assays. They got a new PLA for that. And I think from the end user, CCO end user point of view, just referencing a similar code that is on the fee schedule is this best solution to those, is just to authorize them and pay the I think it's 81445 is the one that's reasonable to pay usually.
81445 for what? For that test?
Any PLA that substantively looks at a bunch of actionable biomarkers or companion testing. Most of the mutations they're looking for in the cancer tissue is querying whether the tumor is treatable with a tyrosine kinase inhibitor or with immunotherapy is what it boils down to for the most part.
I'm sorry, that's 81479.
Well, 81479 is everything in the kitchen sink, so you can't have.
81422.
I think it's 814. I believe it's 81455 is the one.
Yeah, and Carl, we don't set rates, but we can forward that to the folks who have charge of, well, I don't know how PLA rates are set.
Okay.
We usually just do a percentage of whatever Medicare is paying.
I see.
This is Catherine, and excuse me, but could you define PLA for me?
Oh, proprietary laboratory analysis. So instead of CPT codes, a lot of these lab developed tests are called PLA. And they're usually start with a 0. So like 0452U. They always have U at the end. And those are like super specific. It's like a trade name. So,
Yeah, I
you know,
understand now that you said the whole thing.
yeah. So Acme Lab
Mhm.
DNA test for breast cancer would have a PLA.
And Carl, is that the one on the screen that you're referring to, 81445?
Yes, it is.
Okay, great.
And that, so that description there exactly captures the PLA that Foundation Medical just got for their proprietary tumor panel. I think, I forget which one it was.
Yeah, I read that AMA has been advising that they should be billing the PLA where there is one. But it
Right,
sounds
I'm not sure why a certain lab, this is true also of the optical thing, why they got a category 1 for that, and then a gazillion PLAs cropped up right after the category 1 was issued. It makes,
If you could explain the AMA's decisions, that would be great.
I've dropped my membership, but I may reinstate it now so I can ask them.
Yeah, we have been hearing that most states are just ignoring the PLA codes. They don't have them on their fee schedule. They won't pay them. So most labs are just using generic codes, the CPT codes.
I see.
I've also heard some conversation about denying the category 1 codes and requiring use of the PLA codes. So
I'm sure it's all over the place.
It's a pain point for folks that have to make the call yay or nay on these things, just because it's cancer and it's often cancer that's failed initial treatment. So the stakes are pretty high and you feel badly about denying something that could help. On the other hand, it's practically impossible to discern whether what's being asked for could help or not. So
you want to know what you're buying. Yeah.
I had a quick question. Is the FDA considering regulating genetic testing now, or did something pass or something?
They are considering regulating, but I think that is not a done deal yet.
Wasn't this mentioned about a new rule that was effective in May that was
Yeah, the
provided?
laboratory developed test
Yeah.
Yes.
now have new rules, which is a
Yeah.
lot of genetic testing, almost
Yeah.
all. Yeah.
So hopefully that'll help standardize things, but there may be more to come.
I had a question maybe for a future meeting if we fetal whole exome sequencing and when we can reassess that for prenatal cases, because we've got pretty good verbiage for postnatal workup. And I think we've got a lot of evidence to work with now to review that.
So a whole exome sequencing for prenatal.
Yeah.
So
Okay.
is this when there's an anomaly detected and not sure what it is?
Yeah,
like
so
if we've gotten a
whole
normal
exome,
microarray and then
we
we want to
are
do
only covering whole exome for babies in the NICU right now. So that would definitely be a big change.
no, that's whole genome.
Oh,
well,
sorry.
we're not
Yeah.
Whole exome's covered. All you need for a whole exome is a geneticist to order the test. For
for
whole
fetal,
genome,
or are you talking about postnatal right now? I think it's postnatal.
I think it's the entire code for a whole exome. I don't know. I think it's agnostic with respect to tissue.
I've had a prenatal case covered whole exome. Yeah, whole exome for a prenatal case, someone on the Oregon Health Plan, just throw that out there.
Oh, is this on a parent?
No, it was on the fetus.
On an
Yeah, we have
embryo?
whole exome as diagnostic. I can look through our guideline right now.
Okay.
We,
So is
um,
it on villi or amnio?
It was on amniocells.
Yeah, so I think, oh, I see, okay.
okay, I will look and see. Yes, so it's the whole genome that I was thinking about that we really restrict. I believe we're pretty open on whole exome, but I will look to see what our current, if we have guideline restrictions on it. It's not, I don't believe it's in the prenatal genetic testing guideline, which might be one of the problems if it's not listed there.
So this is non-prenatal. Just requires genetic consultation.
And it doesn't restrict it to any situation.
No, that's still non-prenatal.
Yeah,
So it
it's not
doesn't,
in the
not even mentioned.
prenatal. Yeah, so we can definitely look at adding that.
This is D17, yeah. So it's currently just a CPT code that's with no limits for in the prenatal space.
Well, it's not in the prenatal guidelines, so I'm wondering if some of the CCOs are thinking it's not covered because it's not explicitly in there.
Okay. And should there be some guardrails around when that's covered, or is that?
What would trigger the WES on amnio or villi?
Normally, it would be a normal array with at least one structural anomaly. And that could be like cystic hygroma, complex heart defect. I would say like skeletal dysplasia is really good pickup with whole exome compared to panel testing. Or if we've got a cystic hygroma, it's a far superior test than like even what the array usually gives us. So yeah, I would say that it'd be reasonable to have some framing around when it's appropriate. I don't think I would want it restricted to a geneticist ordering it because geneticists are pretty rare to be involved with fetal testing. I think that would be a barrier for a lot of places. But I think it's worth that conversation.
So it would be a high risk OB, or who would order it?
Usually MFMs are.
Okay, so
Okay.
I'm going to put that as a topic to talk about at our next meeting, and I can look into it and see if we
When
need
you
to put
say
it.
don't require genetics, can you say like a geneticist to order? Because I still think you should have genetic counseling and kind of other things with it. I think just having a geneticist as an ordering provider would be really challenging for coverage, like for just
I think we
practically.
just require genetic counseling, right?
Oh, okay. I thought someone mentioned a geneticist ordered it.
So by
Whole exome.
I think it should be just the genetic counselor because we're often
after
working with-
genetic counseling or geneticist consultation.
Okay.
Oh, so do we already have it?
Well, this is in non-prenatal.
Okay.
So this is after the child is born. So this prenatal, sounds like we may need to add similar language to the prenatal.
Right. I think that same language would apply. It's not a requirement that it be a geneticist per se.
So a genetic counseling, geneticist consultation is required. Do you want that, some kind of that wording, or?
I think or would be reasonable.
Yeah, I think that's what the slash does. Yeah. Carl, does that address your concerns, or do you want more specific language around where it's sampled from, or what?
No,
test
I think that's
there?
fine. I think possibly some language that an array had been completed, and maybe some language about a fetal dysmorphism or.
Yeah, I think that's what Jayla was saying, and it's appropriate when with a normal array and one or more structural anomalies seen.
Yeah.
Something like that. So it would provide a little bit more in the way of why you would undertake a whole exome.
Okay. I can look into this. This might be something that I can just send to you all to look at before our November meeting, or it might need to be a whole topic we can talk about at our next gap. Well, once I kind of look into it a little bit more, I'll decide.
Great, thank you.
Thanks for picking that up.
Any other? Right. So I have a couple of follow-up things. I'll send you the updated NCCN references just so you can look and make sure. And let me know if they change before our November 14th meeting. The genetic related CPT codes, I don't think there was follow-up there. The products of conception, I will put something in our prenatal genetic screening guideline clarifying that we covered that. And probably with that, if the whole exome looks pretty straightforward, I'll put wording in there as well, and you can comment on all of that. Otherwise, like I said, I can put the whole exome prenatal screening on our next agenda. Does that sound all reasonable to everybody?
Yes.
Yes.
Sounds great.
Okay,
Yes, sounds good.
great. Anything else? Anything from any of our guests? All right. Well, thank you all. I really appreciate your expertise and your input, and look out for a follow-up email from me. If you could just all sort of weigh in with like, looks good, or nope, change this, whatever you feel is appropriate. This group normally meets only once a year, so I don't anticipate we're going to meet until October-ish next year. But if there's need or things are coming up and you're thinking that we need to address something, definitely send it to HERC staff and we can look at it and possibly convene this group in the interim if needed.
Sounds good. Thank you.
Thanks,
Erin.
everybody.
All right. Well, thank